talking on role of mineralocorticoid antagonist in diabetic kidney disease. When do we need to prescribe mineralocorticoid antagonist in a patient with diabetic kidney disease? So let me write it here. MRA in diabetic kidney disease. So what are different mineralocorticoid antagonists that you know? So one is steroidal compound, another is non-steroidal compound. Steroidal compound and another is non-steroidal compound. So what is the steroidal MRA that you know? Spironolactone, and non-steroidal molecules are finerenone, isagerinone. Okay. So what is the effect of mineralocorticoid receptor in the pathophysiology of diabetic kidney disease? Then you can know, if you block this receptor with MRA, then those pathophysiology will be halted and the consequences can be prevented. So what is the pathophysiology of this mineralocorticoid receptor? When there is activation of mineralocorticoid receptor in patients with diabetic kidney disease, it leads to inflammatory and fibrotic cascade. Inflammatory and fibrotic cascade. And this cascade ultimately leads to kidney failure, heart failure. So if you block this mineralocorticoid receptor with MRA, what happens? These consequences can be prevented. Okay, so that's why we need to give MRA in a patient with diabetic kidney disease. So in which group of patients we give in diabetic kidney disease, in which group we need to give MRA? If patient has albuminuria greater than 30 mg per day, despite on maximally tolerated dose of ACE inhibitors or ARB and SGLT2 inhibitors. In this group of patients, we need to give MRA. So we need to give in this group of patients. And in which group of patients we don't need to give? If GFR is less than 25 or serum potassium is greater than 4.8, we don't give it here. Why? Because it causes hyperkalemia. That's why we need to avoid if GFR is low and serum potassium is greater than 4.8. So you understood what is the indication of MRA in diabetic kidney disease. Now let's talk about two randomized controlled trials from this conclusion was drawn. So the first one RCT was about preventing kidney failure, and the second randomized controlled trial is regarding preventing heart failure hospitalization. Okay, so first let's talk about first RCT regarding kidney failure progression. Okay, so the name of the trial is Finerenone in preventing kidney failure and disease progression in diabetic kidney disease and disease progression in diabetic kidney disease. So what kind of patients were included in this RCT? Inclusion criteria: in patients who has diabetic kidney disease with moderately or severely increased albuminuria. And these patients were already on maximally tolerated dose of ACE inhibitors or ARB. Okay, some patients were on SGLT2 inhibitors and some were not on SGLT2 inhibitors, but the great majority of patients were not on SGLT2 inhibitors. So you can write plus minus SGLT2 inhibitors. And this group of patients also had retinopathy. Okay, so patients with DKD with moderately or severely increased albuminuria with retinopathy on maximally tolerated dose of ACE inhibitors or ARB. It is not plus ACE inhibitors or ARB and plus minus SGLT2 inhibitors. Okay. So in this group of patients, they did RCT, and in one group of patients they give Finerenone 10 to 20 mg OD, and another group of patients what they give placebo. Okay, and they followed this group of patients for 2.6 years, and at the end of 2.6 years they assessed the outcome. Outcome was assessed in terms of all-cause mortality, 40% or greater reduction in GFR, kidney failure means GFR less than 15. So all-cause mortality, 40% or greater reduction in GFR, kidney failure, and the fourth is need of chronic dialysis. And what they found was that in Finerenone group, it decreased all-cause mortality, decreased less number of patients has greater or 40% or greater reduction in GFR. I remember that about 16.9% of the patients in Finerenone group and 20.3% patients in the placebo group had 40% or greater reduction in GFR. This difference was significant, okay, and it significantly reduced kidney failure. It reduced the need of chronic dialysis. But in Finerenone group, there was more patients had hyperkalemia, and few patients discontinued from this trial because of hyperkalemia. So that's why I told you in the beginning, if serum potassium is greater than 4.8, GFR is less than 25, you don't give Finerenone. Okay. So this was regarding first trial, and the next trial RCT was Finerenone on cardiovascular disease progression. So what they found was it decreased heart failure hospitalization, and it decreased all-cause mortality. So from these two RCT, on pooled analysis, what we can say that it prevents kidney failure, it decreases heart failure hospitalization, at a median follow-up of 3 years. Okay. So I already told you that great majority of patients in this RCT were not on SGLT2 inhibitors. Okay, so but all patients were on ACE inhibitors or ARB, not both ACE inhibitors or ARB. Now let's talk about isogerenone. This is also non-steroidal mineralocorticoid antagonist. Regarding this, in randomized control trial, what they found that this has more incidence of hyperkalemia. Significantly more increased risk of hyperkalemia. And the effect on mortality and end-stage kidney disease is unknown. Okay. So, what is the take-home message from this lecture? Take-home message is: give Finerenone 10 to 20 mg OD in patients with diabetic kidney disease with albuminuria, 30 mg per day or greater if patient is already on ACE inhibitors or ARB plus SGLT2 inhibitor, and don't give if G of R is less than 25 and serum potassium is greater than 4.8. Okay, these 2 points you should know.